Gina Lundberg from St. Joseph's Medical Group. She is the founder and medical director of the Heart Center for Women at St. Joseph's Hospital. She's also a national spokesperson for the American Heart Association, and she will be speaking with us today about heart health for women.
Thank you. And I'm so glad to be here. This is February 1, so I get to start wearing red every day this month. I hope you know Friday is National Wear Red Day. So women find a red dress, a red shirt, men find your red tie, or get a little Go Red for Women button here today, and really tell all the women in your lives, your mothers, your sisters, your secretaries, your daughters, your sorority sisters, your classmates, about what you've learned here today, because it's really important. If we're going to lower the deaths from heart disease in women, we've got to spread the word. So some of the statistics about women and heart disease, historically they have not been very good, but they are getting better, and in large part it's due to programs exactly like we're doing here today, getting the word out about heart disease so that women know and then they can respond. Since 2002, there really has not been a decrease in deaths from cardiovascular disease all the way back to about 1976. The information about heart disease has really gotten out to the men, or maybe the women taking care of the men, but we haven't related it to ourselves. So there's really been no decline historically. Some of the 2007 numbers are the first to show an improvement in deaths from heart disease in women. About 1 in 5 women has some form of heart disease, and after the age of 65, it's actually 1 in 3. Between 1 and 2 deaths out of 3 women are still cardiovascular. Cardiovascular disease has more deaths than all cancers combined. About 38% of women who have a heart attack die within 1 year. Very high mortality rate, even if you survive your initial heart attack. And about 40% of women who have heart attacks did not have a single warning system. So this idea that, well, if I get chest pain, then I'll go to the doctor, then I'll look into it, it might be too late. It's like finding the lump and then preventing breast cancer. We have to go see our doctors early and get screened for some of these things. So this is an ad that's run in many women's magazines. You may have seen this in Women's Day, Glamour, Cosmo. And it basically shows the deaths. This is in 2004 from heart disease alone, and this is 361,000 women. Here's stroke, and so when I speak as a cardiovascular doctor, I'm really speaking about both. I want to prevent stroke and heart attack. So that's about 461,000, nearly half a million women died that year. Here is breast cancer deaths, 41,000. And we tend to think that breast cancer is so important in women, and it is. If you have a loved one who's had breast cancer, I'm not minimizing that, but they're more likely to live through their breast cancer and still die of heart disease. So we really have to spread our concerns with our body beyond our bikini area. Okay, we have to think about our heart too. Chronic obstructive lung disease and lung cancer accounts for over 120,000 deaths, again, way more than breast cancer. Colon cancer is the #1 death of cancer in the state of Georgia, also not breast. So there's a lot of other parts of our bodies we need to be thinking about. Now this is the 2007 data, and as I was telling you, from the 1970s till 2002, here's women in red, really no change in the total deaths. And here's men in the blue, steadily declining. So we've done a good job in them. Around 2003 is when we kicked off Go Red for Women and the American Heart Association's campaign. And as you can see, in 2007, the number of deaths is down for the first time in both men and women. Now do we have any accountants or math majors in the audience, math teachers? What I want you to look at is this area between the two lines, because this is what we don't think about. This is how many more women have been dying every year, even now, than men with heart disease. So it's not a man's illness, it's a woman's illness. So we really want to see these lines merge and men and women do equally well. There really has been a gender difference. Now, some of the typical symptoms of heart disease, and again, we don't want you to have these symptoms, we want you to prevent them, but should you have these symptoms, we want you to know what they are, because they can be tricky in a woman, or I like to say women's symptoms are more subtle. They're not really the textbook pictures. It can be pain, pressure, squeezing, even kind of a stabbing feeling really anywhere in the chest, okay? You think it's gonna be here from TV, but it can be on the right side of your chest, it can be up in your jaw, it can be in your neck, it can be in your upper back and shoulder area, it can be like right between your shoulder blades, it can be even upper stomach, and it can be your left arm or your right arm. So really anywhere in your whole chest area can be a symptom of heart disease. So the question is, you know, these are a lot of vague symptoms. When do I go to the doctor? You want to be much more aware of your risk factors. So if you have multiple risk factors, and we're going to cover all of those, you need to be more concerned. As you get older, you need to be more concerned. And if they occur with exertion, like when you exercise, when you walk up the stairs, when you walk up the hill to the classroom or whatever, then it's a lot more concerning than if it happens at rest. But there's also this feeling of impending doom, of something's not right. You need to pay attention to that, and we're going to get to that in just a second. So these symptoms, you know, if you're 22, it's probably not your heart, but I've taken care of a 24-year-old who had a heart attack. So nobody is too young to have a heart attack. An irregular heartbeat, feeling like your heart's racing, pounding, irregular, even feeling like you're going to pass out. That can be a serious heart problem. This feeling of I can't get a good deep breath, just inadequate breath. Not winded when you exercise, that's appropriate, but just feeling inadequate, shortness, inadequate air. Nausea, vomiting, that can actually all be heart attack symptoms. A lot of women sit home thinking they're having the flu. I got a stomach bug. No, you're having a heart attack. Cold, clammy skin, breaking out in sweats. Now, you know, a lot of perimenopausal women have that symptom, but it also can indicate a heart problem. Dizzy, and then what a lot of women mistakenly call heartburn. That can also be your heart. Some of these more subtle symptoms can be, I just don't feel right, I'm weak. This feeling of something's wrong. We call it impending doom. Something is not right. Feeling, you know, something's wrong. I can't do things I used to do. I don't feel as good as I used to. And sometimes we think it's a heartburn, and then again, it doesn't have to be pain. A lot of women will say, it's not pain, it's just a little discomfort, it's just a little heavy. It doesn't have to be crushing, bring you to your knees pain, because women are pretty tough, right? We're the one that have the babies. Sometimes it's what we would call really mild discomfort. So what are the risk factors for heart disease? Well, these are the traditional ones, and diabetes is at the top of the list because it is the #1 risk factor in women. If you have diabetes, you need to be followed very closely by your primary care doctor, maybe even better yet, if you're over 35, a cardiologist. Because even if you have well-controlled type 2 diet-controlled diabetes, you're still at risk as if you took insulin 3 times a day. So it's kind of, I tell women it's like being pregnant. You can't be a little pregnant, you're not a little diabetic. If your body can't metabolize sugar, you are at risk. High blood pressure and high cholesterol get all the data because we have great medications to treat them, and their numbers. You can just track them. It's a lot easier to figure out than some other risk factors. Smoking is the #1 preventable cause of heart disease in women, but it can also be one of the hardest ones to change because that's a very strong habit. If you can quit smoking, you reduce your risk of heart disease dramatically within 1 year, and within 10 to 15 years, you're back to as if you had never smoked. Family history, this is mom, dad, brothers, or sisters having heart disease, and the female relatives before they turn 60, and then in the male relatives before they turn 50. Because cardiovascular disease is the major killer of women and men, we all have grandparents and aunts and uncles who have died from heart disease. That doesn't necessarily mean you're at risk, but if there is a strong family history, you want to get that checked out while you're still young, probably before you're 30, 35. Obesity, it's very easy to be obese these days. The BMI is 30 or higher. Morbidly obese is 40 and on up. In an effort to reduce deaths, we've gotten more stringent on our blood pressure numbers, our blood sugar numbers, our blood glucose numbers, our blood cholesterol numbers, and we've also gotten more stringent on weight. So a BMI of 30, you might just feel a little overweight, but you might be medically in the obese category. Postmenopausal women or women over 55. Most women are postmenopausal by 55. A few, it doesn't happen until 58 or so. But if you've had your ovaries removed when you were young surgically, or you've gone through natural menopause, that is a risk factor. And then sedentary lifestyle. And probably most of us in this room are sedentary. Unless you're spending 30 minutes, 6 days a week doing moderate to vigorous exercise, on top of all your activity of walking around, shopping, cooking, cleaning, all the things we do, you're considered sedentary. So unless you're really putting in the time on the treadmill or outside walking, it doesn't count. It doesn't matter how active you are. Now we have a lot of new risk factors that have been getting a lot of attention, and they're very helpful, but the traditional ones I just went over are still the most important. We have advanced cholesterol testing, inflammatory markers. We're learning that rheumatologic disorders, lupus, rheumatoid arthritis, some of these inflammatory markers put you at increased risk of heart disease. And in diabetic and overweight women, they tend to have higher inflammatory markers. Insulin resistance is a pre-diabetic condition where you tend to gain weight around the tummy, your blood sugar's going up, but you're not quite at the diabetic level. Metabolic syndrome, I'm going to tell you the criteria for that in just a few minutes. Subclinical atherosclerosis, this is when you've gone to one of those screening programs. We have one at St. Joe's I'm going to tell you about, but also like life screening. You may have had a carotid intermediate thickness test, a test on your aorta, a CAT scan of your heart. Any of those things that show you already have blockage, but you still haven't had any symptoms or any problems. Early detection testing, we're going to go over, and genetic testing. More and more we have more DNA markers that tell us if you're at risk for heart disease or not. Now, the American Heart Association and the American College of Cardiologists got together in 2003 and set up the first guidelines of how we should protect women from heart disease. And unfortunately, many, many physicians did not embrace these guidelines. Who are most women seeing? Your gynecologists. Are they going to be following cholesterol and blood pressure treatment guidelines? Not often. That's just really not what they feel is their area of expertise. In 2007, there was another update, and again, it said we have to get to these women early. We have to work on prevention. And then this is the 2011 update. And so the guidelines are not new. If you're seeing a doctor who doesn't know about them, isn't periodically checking your blood pressure or the cholesterol, you might want to get a more up-to-date doctor. So the evaluation for heart disease is that when you meet with your doctor, you all should talk about your parents, your family history, brothers and sisters, pregnancy, and even your, if you're older and you've gone through menopause, some of those things. If you've had a pregnancy that was associated with high blood glucose, what we call gestational diabetes, or maybe a baby who was over 9 pounds, or high blood pressure during pregnancy, and definitely if you had anything like preeclampsia or eclampsia, those all put you at higher risk for heart disease when you get older. So you need to be talking about that. They need to be watching you more closely. You need to talk about the symptoms that we've gone over. You also need to talk about depression. Depression leads to heart disease leads to depression. So if you're feeling like, I don't want to exercise, I'm tired, I don't want to get out of bed, those are all things you should talk to your doctor about. You need a physical examination that includes blood pressure, your body mass index, and a waist measurement, because that's how you know if you're getting close to the obese or metabolic syndrome category. You need blood testing for fasting cholesterol and glucose. Usually between 20 and 30, you need it about twice, at 20 and 25 and 30 again. After 30, you might need it every 2 to 3 years, and after 40, you definitely need it every year or two, and after 50, you need it every single year. And then we have these risk assessments, Framingham Risk Assessment, Reynolds Risk Assessment. You all are very computer savvy. I'm sure you can pull up Framingham Risk and you can plug in all your numbers, or Reynolds Risk and plug in your numbers, and see what your risk of heart disease is now, but even more important, what is it in 10 years and 20 years? Because that's really what you know. I may be healthy at 25, but am I still going to be healthy at 50? So high risk is if you know you already have heart disease, and I'm going to assume, since this is a fairly young crowd, that no one here already knows they have heart disease. Had a stroke, or what we call a mini stroke, sometimes TIA. Peripheral artery disease, that's blockages in the legs that cause pain or heaviness, blockages in the neck. An abdominal aortic aneurysm, that's an enlargement of the aorta. Diabetes and chronic kidney disease, these can happen young. These can happen, actually we're seeing type 2 diabetes in our middle school kids and high school kids. So it certainly can be happening in the college years. And then this global risk of being elevated for heart disease. These are all people who are at high risk and need to be followed very closely, probably under the care of a cardiologist. Now this is an example of the Framingham Risk, and as you see, you just plug in your age, your gender, your cholesterol, your HDL, that's the good cholesterol, do you smoke, do you have high blood pressure, and click on the button and it will tell you what your risk of having a heart attack is in the next 10 years, and then you can plug in your age at 50 or whatever you want to know, something 10 years from now, and it will tell you your risk then if you don't change your risk factors. Well, beautiful thing is when I start working with a patient, we get her cholesterol down, get her blood pressure down, we can plug in her new values and see how much we've changed her risk for heart disease. Some people go from a 12% risk of a heart attack in the next 10 years to a 3% risk, which might be exactly what's appropriate for her age. So it's very exciting to actually see your risk go down. This renal score was set up for women, and it adds a few more things like the C-reactive protein, the inflammatory marker, as well as your family history. So we think it's a little bit more specific in women. In all honesty, both of these risk assessments underestimate the risk in women. They're more reliable in men. Why is that? Because we don't get enough women in the research studies. And we really have to start seeing research studies have 50% women, be ethnically diverse. We want to know about Hispanic and Latino women. We want to know about African American women. We want to know about Mexican women. We want to know about all women. So if we don't get more women of different ethnic backgrounds in these research studies, we're never going to know what works best in women. Right now they take a lot of data from, a study can be 85% white males, and then they try to tell us how to take care of women, and I say, I'm sorry, but I'm not taking care of white males, I'm taking care of women of many backgrounds. So we've got to get in the research studies. So who's at risk? Well, basically if you do any of those things I talked about, including eat too much fast food, poor diet, physical inactivity, family history of young heart disease, all of these things lead to you being at risk. Metabolic syndrome, I'm going to tell you about this, I keep promising. Autoimmune disorders, rheumatoid arthritis and lupus have already been established as risk factors for heart disease. Probably other autoimmune and other inflammatory illnesses are too. We just don't have that data yet. And then I told you about preeclampsia, gestational diabetes, high blood pressure, and pregnancy, all very important for your risk. So here's the metabolic syndrome. There's 5 factors, and if you have 3, 4, or 5, you have metabolic syndrome. 5 being more concerning than 3, obviously. They are, if your waist is over 35 inches, we've all got a tape measure, so you can figure that out easily. If your blood pressure is 130 or higher, or 85 or higher on the diastolic, if your fasting glucose is 100, and then again, the one we know the most about, triglycerides over 150, and in women, your HDL, your good cholesterol, should be over 50. And in a young woman, it might be 70 or 80 is appropriate. It's going to go down with every birthday, and it's going to really drop at menopause. So you want to start high, because you're going to finish much lower. So pretty much, if you're under 30, your HDL should be probably 75 to 80. And then optimal risk. We did a study with our Women's Heart Center. We compared it to other women's heart centers around the country. About 3% of women in America meet this ideal. I don't. It's a heart-healthy lifestyle, 180 minutes of moderate to vigorous exercise every week. So that's the 30 minutes, 6 days a week. 30 minutes, 6 days a week. And moderate to vigorous, sweating, hard working. Ideal blood pressure, body mass index, weight, and a waist under 35 inches. Ideal blood glucose, and no risk factors. And I'm already 50, so there you go.
That woman even exists.
Yeah, well, she's 25 and she lives at the gym.
And hasn't had
And her parents are healthy. She picked her parents up. Yeah, there's 2 to 3% of American women actually meet this goal. It's a lofty goal, but we should all aspire to it. So what can we do? Well, lifestyle, behavior modifications, those are really the best, easiest things. If you smoke, quit. If you don't want to smoke, but don't want to quit smoking, you're not going to quit. But once you get to the point where you want to quit, sit down and talk to your doctor. There's a lot of good techniques out there. There's a Detrol inhaler, so you can still feel like you're smoking. It's a little cartridge. There's patches, there's gums, there's 2 medications now. One of them has a 50% chance of helping you stop smoking even more. So get your resources, decide you want to do it, and then go for it. The exercise, one of the best things you can do on a campus like this is get a pedometer. You try to walk 10,000 steps a day. That would be considered ideal. 5,000 would be the minimum. Or go to the gym and get on the treadmill or the elliptical or the bike. 30 minutes, 6 days a week. Heart-healthy eating, I'm going to tell you more about in a little bit. Weight management, that's tough. It's really tough as you get older, as you're more sedentary, when you're busy studying. And everybody talks about freshman fat and sophomore spread. And it gets worse in graduate school and medical school, and it just is always there. Depression, really important to identify that early. And then cardiac rehab after a hospitalization. In 1990, only 3% of women were enrolled in cardiac rehab. It was all white males. Women need to go exercise after a heart attack and go to cardiac rehab, which is our exercise program, to improve their long-term outcome, to stay out of the hospital, to learn heart-healthy lifestyles, and to do this in a nice monitored environment. So if you have a loved one, let's say your mother had bypass surgery or a valve surgery or a stent, say, Mom, are you going to go to cardiac rehab? We have a wonderful program at St. Joe's. Atlanta Medical has one. Piedmont has one. Almost every hospital has one. Really encourage your loved ones to go to cardiac rehab. All right, so these are the numbers you want to know. And this is ideal. You want an LDL, and the way I teach it's kind of simplistic, so don't laugh at me, but LDL is lousy, so you want it low. And you want it under 100. And if you're very high risk, you want it under 70. HDL is healthy, so you want it high. And in all women, it should be over 50. The higher, the better. The younger, the higher. Triglycerides are terrible, so you want them tiny, and you want it under 150. And then non-HDL is a newer marker, and it's actually even our best marker. What it is you take your total cholesterol, and you subtract out your HDL, and you want that to be under 130. If you've ever looked at a cholesterol profile, you can't add the LDL and HDL together and get the total cholesterol. That's because we have an IDL in there, intermediate density lipoprotein. And we don't tell you about that one because you know how doctors don't want to tell you all our secrets. But the IDL is bad too. So if you measure your non-HDL, you've encompassed all the atherogenic or cholesterol plaque building particles in this number. So it's even more important. If you're really high risk, you want that one under 100. So LDL lousy, low, HDL healthy, high, triglycerides terrible, tiny.
So the non-HDL equals the IDL and the LDL. Okay.
And the VLDL too.
Will that be, I just got my blood work done, will that be listed out there? Or?
Probably the VLDL will be on there, but not the IDL.
Okay.
But just do the total and the HDL and you've got it.
Okay.
Okay? And that way you don't have to have a biochem major.
Explain.
Yes. All right, so lipid management. Omega-3 fish oils. Very helpful if you already have heart disease or elevated triglycerides. Fish, particularly salmon, tuna, mackerel, the fatty fish, very good for you. If you don't like fish, then maybe go ahead and start some fish oils as part of your routine supplement. Very good overall for skin and hair and joints and other things women worry about. So I think that fish oils in women is usually a good idea. Niacin is a B complex vitamin. It is over the counter, but you don't want to start taking this without your doctor's approval because you'll flush. You'll have hot flashes at night, and you don't want to have those unless you've been instructed on it. Fibrates are a cholesterol medication. One of the reasons I bring up omega-3 fish oils, niacin, and fibrates is everybody thinks if you go on a cholesterol medicine, you're going to get a statin. And statins have really got a lot of bad press. Statins are our best drug in LDL lowering, but not everyone needs a statin. And so it's not one size fits all. You need to go see a doctor who deals with cholesterol and get the medication that works best for you. And that's generally if diet and exercise fail. Blood pressure optimal number is less than 120/80. If you are a diabetic or high risk, we think that probably 130/80 is as low as you need to be. You don't need to be lower than that, but the rest of us do. If your blood pressure has been running 120/39 systolic or 80/89 diastolic, you're not borderline anymore. You're pre-hypertensive. And we changed that phrase so you'd really get the full impact of you're on your way to high blood pressure. You're not okay. I've seen women who've been told for 10 years you're borderline. Well, after 1 year, we should probably start treating you. So we don't believe in borderline blood pressure anymore. You're pre-hypertensive. We're watching you closely. Usually at this stage, you can reduce your sodium, which is in everything, and exercise, maybe lose a little weight, and maybe get back out of that pre-hypertensive stage. We are learning that the sooner we treat people for blood pressure, even if it's in your 30s or 40s, the more likely we are to prevent eye damage, kidney damage, strokes, and heart attacks. So you don't want to wait till your kidneys are already kind of halfway shot to say, I'll go on blood pressure medicine. You want to protect your kidneys. And if you're over 140 over 90, we probably should put you on medicine right away. You have a question?
Just with regards to the fish oil, just a note on mercury in fish oil. Because I'm sure when you talk to a patient, you say you got to be mindful about what brand you're choosing.
Well, that's one of the reasons actually to not eat the fish to get your fish oils, is there's still a lot of problems with mercury. There's one prescription brand, it's called Lovesa, and it has been really purified to clear it of any mercury. A lot of the over-the-counter brands don't have to meet any FDA guidelines or purification standards, so they're not as good. So it's a matter of, do you trust the over-the-counter brand? I would go with somebody who has a lot to lose, like Bayer, Johnson & Johnson, somebody who's held to a higher standard than some of these things you get at the health food store. But you want to, if you're not eating fish, you probably want farm raised as opposed to ocean raised for the mercury. It is a concern.
Particularly for pregnant women.
Yes, and the canned tuna is the worst on the mercury. All right. So the heart healthy diet. The heart healthy diet is 7 to 10 fruits and vegetables a day. Now, is anybody getting that? Good for you. Are you a vegetarian? Are you a vegetarian? Okay. Any vegans? Okay. If you're not really making an effort to get in your fruits and vegetables, most of us are not achieving this goal. That means you're having fruits and vegetables for breakfast, lunch, dinner, and all your snacks. And I've had patients say, well, if I ate 7 to 10 fruits and vegetables a day, I wouldn't eat anything else. And then I go, yeah, that's kind of the goal. We want you filling up with fiber and good nutrition, and then eating small portions of protein and small portions of breads and grains. When you eat, we want whole foods, not processed. So like in the South, I tell people, you want to have like grilled squash, not squash casserole like Mama makes. You want to have regular green beans, not green bean casserole. You want to have, unprocessed whole foods as opposed to totally processed, added butter and fat and gravy and mushroom soup and everything else we put in our southern cooking. So you want to eat nice grilled, steamed vegetables. You want less than 7% of your calories to be from fat, and you want no trans fats. And you really want to limit sodium. 2.3 grams per day is basically 2 teaspoons, and that's already in everything we buy. It's in the water, it's in everything. So even if you never add the salt shaker, that does not mean you're eating a low sodium diet. You have to actually be buying products or cooking fresh. Cooking fresh is hard. Okay, so we want to keep your blood glucose under 100. That means 99 and down. The younger you are, it probably should be in the 80s. Body mass index under 25 is ideal, over 30 is obese, and the waist under 35 for sure. So what have we done at the Heart Center for Women? Well, we've kind of appreciated that women aren't getting the message and women aren't getting screened, and so many women under the age of 50 are still seeing their gynecologist. So we started a program to screen and educate women. We also work with community programs like here today to get the word out. We also put on a program for physicians so that your physician can come to our program and learn about the guidelines for women as well as the latest studies, what we can do to get your physician treating you properly and gender specifically. And then we try to get you set up with primary care doctors who are also following the guidelines. We do the Reynolds Risk and the Framingham Risk. We give you all the numbers we talked about. We also talk about healthy eating, smoking cessation, and stress reduction. All of our individual screenings are done by our nurse practitioner, Stacy Jasquitz. Say hi to everyone. And if you have any questions about those things, she'll be glad to answer them at the end. We also encourage research. As I said, this is key to understanding how to best take care of women. And if you need a physician, we will help with that. These are our websites, and let's get to some of this advanced screening. So this is actually a CAT scan of the heart. Let me sort of orient you here. This is the aortic valve. This is what we call the left main artery of the heart, and this is the LAD, the left anterior ascending that goes down the front artery of the heart, and this is the circumflex. This is the sternum, the breastbone, and back here is the back. And so this is the the left shoulder, this is the right shoulder, and we're at the person's feet looking at their head. Got it? And all these big white chunks that look a lot like bone, that's calcium in the arteries of the heart. That's what atherosclerotic plaque looks like. And can you imagine, this is the blood in the aorta. Can you imagine how does it get past all of this to get all the way down to the arteries of the heart and supply you without chest pain or shortness of breath? Well, in somebody like this, they're going to need bypass surgery. That's an awful lot of blockages. But this is what it actually looks like. And the CAT scan can show us, are you still a prevention patient or are you a disease management patient? We don't usually recommend this CAT scan of the heart in a woman before she's 45. That's really about the time that these blockages start to calcify. Unless you tell me, you know, well, your mom had a heart attack at 40 or dad had a heart attack at 32, we would start screening you much earlier. But in general, a woman under 45 does not need this test. So, in summary, heart disease, coronary artery disease, is the leading cause of death in women. It has been for the last 40 years and unfortunately continues to be. The evaluation of chest pain in women with your physician, even with an ER doctor, a cardiologist, can be very difficult because women don't follow the rules. Our symptoms are much more scattered, so we need more testing. If you go to your doctor and tell them you have chest pain, they cannot tell you it is or it is not your heart until after you've passed a stress test. So be your own advocate. Say, shouldn't I have a stress test? If we tell a man he needed the stress test, we should certainly be telling the woman she needs a stress test. And again, make sure your doctor knows about these guidelines by the American Heart Association and the American College of Cardiologists. Make sure they're following them. You're worth it. Be your own health advocate. We all have been a very interactive audience. Thank you for having me. And please wear red as much as you can this month, but everybody wear it Friday. Okay? All right.
Well, let's give Dr. Lundberg a round of applause.